talk about combat medicine. الناس الشباب اللي في الغرفة يذكرون مسلسل اسمه ماش. If you haven't seen MASH, I would recommend that you go to YouTube. إذا أحد حي من الجيل هذاك had time to upload it into YouTube. دكتور ماجد يتذكره أكيد يعني. Sarcastic. طيب. So we're going to talk about combat medicine. During this period of time in Saudi Arabia, we have a war going down in the south. And I'm sure that a lot of the people in this room have been involved in one way or another as emergency physicians, either by working in the south or by answering questions to colleagues in the military field, National Guard or military hospital. I know that we're in KKUH. It's not a military hospital, but I'm sure that we have great people here who have been involved in something like this. I don't like to segregate. There's no such thing as segregation between hospitals. We're all one institution. I try to avoid any kind of, sarcastic? 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 أنا بجلس هنا نطلع سلايد هذه لو إلى يوم القيامة. Sarcastic? Sarcastic? أقدر أقدم مكتوبة قدامي هنا بس الصورة هذه ما تقدم يبغى لها شعب كامل يقدمها يا أبو. Okay, so as I said, I don't like institutional segregation. My presentation has nothing to do with segregation at all. كنت بحط الكي مارك بس ما تكفي. طيب, so why is combat or military medicine important? First, it's a very sensitive subject. When you're talking about victims, you're talking about victims who are most likely people who are soldiers or in the military field who are there to protect us. And who are, they're heroes to everyone. And also that there's tons of money put into that industry. When you're talking about military medicine, you're talking about companies that their sole purpose is to produce equipment and medication and things like that that go into that specialty. And we don't know, does it really make a difference or not? For the purpose of this presentation, I've reviewed analysis of literature from starting with Vietnam, Korea, World War II, and they've also looked at the Iraqi and Afghanistan war, and all the literature, and it's published there. There are a lot of references that look at military medicine and in detail. The surprising thing is that death is constant. The percent of people dying from wars is constant, even with the, the advancement of medical equipment and so on. So why do people die? Why do you think people die in combat? What are the causes of death? أكيد injuries. راح نسوي مناكير يا دكتورة. طيب. At least the last one يعني. So why do people die? Infections, bleeding. So this is the distribution. Look, so penetrating head injury is 34%. How many people have you seen who arrest from penetrating head injury and then come back alive? So not that much, huh? 27 is uncontrollable trauma. Preventable trauma is 11%. 10% is exsanguination. If you look at the 2%, that's airway. And when you look at people who prepare medical equipment to go to military, we have laryngoscopes, LMAs, combi tubes. We have all the kind of air equipment, crikes, and only 2% die of that, right? So that really tells you that's not funny. So this is a study, it's an interesting study. They looked at all the casualties from Special Operation Forces who died between 2001 and 2004. And the Center for Forensic Medicine in military is in a place called Dover, Delaware. And they conducted autopsies on all of these casualties. They had a forensic pathologist, they had a military and civilian trauma surgeon, they had a trauma nurse, they had a combat medic, which looked at these casualties. They looked at the injuries, the cause of death, and they looked at the education and the equipment that was with the people who were providing care at that instant. And then they put them in two different categories. Were they non-survivable or were they potentially survivable? Another large study looked at all the casualties from the Afghanistan and the Iraqi war between the years of 2001 and 2011. The previous study looked at all death, regardless of where it happened. This study only looked at combat death or battlefield death. They also took them to the same place. They had a trauma surgeon. They had a forensic pathologist who does the autopsies, preventive medicine physician. They had a person who's expert in code entering and so on. And they also put them in two categories, either potentially survivable or non-survivable. What do you think the results were? So to me, they were extremely surprising. So, the patients, 73 died from explosions, gunshots were 22, vehicle crashes, industrial crashes, things that weren't related to the battlefield, 4.2, and blunt trauma was 6%. What was very interesting was 87% of the mortalities happened in the pre-medical treatment facility before they even were able to go to any clinic or hospital. 76 to 85 were deemed non-survivable causes. So whatever you had then wouldn't have changed the outcome. So we're talking about almost 90% of our victims are going to die before they arrive to any field hospital or combat hospital or a surgeon. And 76 to 85% were non-survivable causes. So what we're talking about is around 15% of the patients that we can really work on. So what were the survivable causes? So survivable causes were truncal hemorrhage, junctional hemorrhage, compressible hemorrhage, and sepsis. So 13% was sepsis. Around 30% was compressible hemorrhage, which these two groups we can work on. Junctional hemorrhage we can also work on with certain kind of junctional tourniquets. But when you look at the biggest is truncal hemorrhage, where around in both arms around 50 and 67%. And maybe Dr. Jala can talk later, even as a surgeon, it is very, very difficult to control a truncal hemorrhage. So, majority of combat-related deaths occurred in the field, and most of these casualties will die regardless of whatever you provide. Very few deaths were potentially preventable with the most advanced kind of training or trauma treatments. So, what should we do? We should focus on treating the potential preventable causes of death on the battlefield. Subgroup of injury is very small of overall injury, but when you're treating a trauma in the field, what does it mean? You're either being shot at, or you're under fire, or you're delaying a whole team of advancing to a certain place. So it's not without a price. In 1996, these two famous people, U.S. Navy Captain Frank Butler and John Hagman, came up with the Tactical Combat Casualty Course. If there's anyone from the military here, this is like the PHTLS or ATLS of anyone who goes to combat. It was developed for special operations forces. The guy on the left is Butler. Hagman, I tried my best to find a non-pedophilic serial killer picture. I tried my best. I searched the internet. I called Google. I called the army. They couldn't. This is the only picture they could have given me. So I had to search. If you have a picture like this on the internet, you have to search about the person, right? So they're both physicians. Hagman was accused because of this course and this training. He received tens of millions of dollars for the course, and it was all taxpayer funded. Animal rights activists were very angry. They were very angry because he used pigs, live wounded pigs, to train people or to develop new methods of treating trauma. But this is how it is. This is how science is, right? People investigated into it. They said it was cruel, but found out, science is important. And he didn't only use pigs to do that. The guy was, and he went a step further. So he had a place called the farm. During 2012-2013, he had military personnel training in the farm, and he gave them drugs and liquor. And then he asked them to perform horrifying medical procedures on one another. But at least, we know that he's doing it for trauma care, right? It's for a cause. He also gave, he also gave 10 students ketamine. It gets more, fun. It gets, step after step. So in the farm, he asked students to insert catheters into genitals of other trainees. 2 intoxicated students were subjected to penile nerve blocks. أكيد في سبب يعني. Sarcastic. He also exploited for personal gain and for sexual gratification. ما أدري في الكورس هتدرسونها يا أنتوا أنتوا. في شيء له علاقة في يعني. طيب sarcastic. طيب. But there was something very good that he used, sarcastic. So he had medical students, and he put them in a place called the shock lab. And he would withdraw blood for them until they went into shock, and then he would give them back the blood, just to see any stages of shock and so on. So that's a very good use of medical students. I would recommend, أنا مسحت الرجال كل قالوا الماضي. I recommend we start doing this with our medical students. شو ولا واحد رمى شوف الجبناء. ظلام ترى ما أشوفكم. طيب. So back to the subject. Regardless of what they said, they developed this course, and they described 3 zones of care during combat. So they called the first zone called care under fire, and during this zone, the only things you're supposed to do, and is it Dr. Layla Hadar here? So this also works for for special forces والاقتحامات وما إلى ذلك. So care under fire, the only 2 things that you're allowed to do is tourniquet for massive hemorrhage, and the recovery position for airway. So you don't intubate, you don't do surgical airways or anything like that. In tactical field care, this is where most of the TCCC happens, where you can do a lot of other procedures, and I'm going to go through them. And then the TAC-EVAC, or tactical evacuation care, where you take patients to special centers. When you see all of this, it gives you a sense of what we should be doing in the field, right? Should we be there doing thoracotomies and surgical airways and intubation and so on? When 90% of our patients die before they reach the hospital, when 85% have non-survivable injuries. Okay, so this is the list of things that you can do or you're trained on in TCCC. I don't know if you can see it at the back. It's a long list. Long list has tourniquets, airway maneuvers, supraglottic airway, endotracheal intubation, chest tubes, administering oxygen. I looked at the things that I think that make a difference. So you're talking about applying a tourniquet, applying direct pressure, casualty movement, because we have to evacuate patients to safer environments, treating suction or sucking chest wounds, and also preventing hypothermia. The question is, how many medical students do we have here So we have a big number. I'm not being sarcastic. I'm being so at the end of your training, 7-year training, does any one of you feel comfortable intubating? No. Yes? بعد المحاضرة نتكلم. I'm not sarcastic. So inserting a chest tube. How many of the medical students how about using an intraosseous gun? Okay. So we're talking about a lot of procedures that take a lot of time to teach. We're not talking about simple things to do. And when we're sending military medics to the field, there are people who have 2 years training, what they call المدارس العسكرية. So can you teach in 2 years? Can you teach all these procedures? No. But we are still purchasing these equipment. How much can you carry? You saw the list of what we were talking about, right? Can we carry all of these things in one bag? When you look at this picture, Hamdan, and look at the back, the guy dying in the back, Sawi, gasping for air. Sawi just ran with the equipment that Hamdan has. All he has is a defibrillator and a bag that has simple stuff like splints and so on, and a suture kit. That's all he has. Can you send someone to war with this? احنا في استراحة ولا had to group out الشيش والمعسلات واستراحة. They couldn't do it. It's heavy and it's a lot to carry, especially when you still have your military stuff with you, your gun, your rifle, or whatever. So when you consider things to take with you if you're consulted, I'm talking to my colleague consultants and whoever is going to graduate in the coming years. When someone asks you what should we have in our bag, think about things that are safe to use, because these people don't have enough training. You'll never have enough training to go to war. Can be used well in the pre-hospital and battlefield tactical situation. Is small, lightweighted, low cost, because you need a lot of it. Easy to use, requires minimal training and familiarization. Long shelf life, because these things are not going to be used a lot, right? And inshallah they're not, but they're usually not. Usually they expire before you use them. And stable in different environments, because if you get something like tranexamic acid that needs to be cooled, and you send someone to Najran, which in summer gets really hot, will it be useful? It won't. So think about stuff. You can send whatever you want, but you have to be very careful on how to use it. Also to keep in mind the skill level of the person who is providing care in the field, the type of the mission, and the length of the mission. How long are they going to be there? I put an example of medical bags, if someone wants to look at later. I'm not going to go through them all. So this is called the compact pill pack, because someone in the back said that people die of sepsis, right, or infections. And people when you get shot, you get pain, then you get an infection. So they give them Lexicam, acetaminophen, and moxifloxacin. And then they ask them to take all 4 pills, because they're not doctors. You have to tell them, if you get shot, take all 4 pills, واشرب معها موية, because يمكن ما يشرب معها موية. Being sarcastic. طيب. Improved first aid kit also has a bunch of stuff. This is one of the most famous, called the WALK, Warrior Aid and Litter Kit. Has more detailed stuff to use. And I can also provide this, all the articles to support it also. In summary, we have to review and understand and track patterns of injuries of our soldiers, what they sustain in the field. I know that we don't do that, and I don't know if military or MOI track the type of injuries they get. We have to reduce the time between the battlefield, point of injury, and the surgical intervention, because as we know that most of what you can do in the field is probably worthless. To establish evacuation policies, which patient gets transported, because we do have to choose. You have a limited number of resources, limited airplanes, limited ambulances that you can use to transport patients, so you have to be very, very careful in choosing who you're going to transport. Also, to develop a comprehensive and direct curriculum for our field medics, just to tell them what to do, how to do it, what's important, what's not. We waste a lot of time training people on doing intubation, and we know that intubation doesn't make a difference. Even us in the room, after we leave here and we still go back to teaching people how to intubate, not teaching how to develop evidence-based procedures. Also, to develop proper evidence-based medication equipment packs. All the information on military casualties and so on is published. There are multiple journals that publish with the type of injuries, the type of weapon that caused injuries, and infection, and what treatment worked and what did not. So please go back to that. You don't have to make up things. Don't use your common sense. Go use evidence-based resources. And thank you very much.